Good morning, or good evening, I suppose is more appropriate. It's still morning in the US. We'd like to welcome everyone to the faculty development program around medical education. Today, we have a number of sessions that promise to be really useful. We have Dr. DK and Dr. Rice talking about using simulation as a learning tool. Doctors Regan and Ritter will be looking at assessment and evaluation and what these terms mean and how we can apply them. And then Dr. Haas and Dr. Salo will be talking about feedback and approaches to having those challenging conversations around performance. Our initial session, as I mentioned, is going to deal with simulation as an instructional tool and feature Dr. DK from the University of Cape Coast, as well as Dr. Julie Rice from Johns Hopkins University. And I am going to go ahead and turn control over to them.
Okay, let me just bring up our PowerPoint here.
And as they're setting up, I'll just let everyone know, for those of you new from last time, we're going to be periodically putting things like evaluation forms in the chat so that we can continue to develop these programs to meet everyone's needs. And also the chat is your primary means of communicating with us. So if there are questions you would like to have answered, comments, insights, please feel free to share them with the group. And I'll moderate through them as they come up.
All right.
Okay, and just briefly, Dr. Laura, can you just remind me of when our stop time is so I'm mindful of that?
I have you going until 16:55, and I'll give you a heads up.
Thank you so much. Okay, Dr. DK.
Awesome. Hi. Hello, everyone. Thanks for joining us today. Dr. Rice and I, we're really excited. We really look forward to this day. We're excited to kick off the session discussing simulation as an instructional method in medical education. While, the topic of simulation is a lot broader than just the 45 minutes we have to speak, we'll be providing you with kind of like an overview of what it really is and just get you thinking. We're hoping that we'll provide you with enough to get you thinking about how to integrate this into your own teaching context. I'm Dr. Nkechi Oluwakemi DK. I'm an emergency physician trained in Confanoche Teaching Hospital with a fellowship in medical simulation from Mayo Clinic, Florida. I'm currently a senior lecturer in the School of Medical Sciences, University of Cape Coast, where I've been tasked for over a decade with clinical skills training, and more recently with integrating simulation into curriculum. Co-presenting with me today is my colleague, Dr. Julie Rice, who I'll let introduce herself, and let's get this started. Over to you, Dr. Rice.
Well, thank you very much, Dr. DK. So I'm Dr. Rice. I am an assistant professor of emergency medicine at Johns Hopkins in the Department of Emergency Medicine. I'm the director of the Emergency Medicine Department's simulation-based education program, where we teach our residents and sometimes have the opportunity to have multidisciplinary and interprofessional sims with other departments and other professionals in our department. I'm also affiliate faculty with the Armstrong Institute for Patient Safety, and I'm very excited to bring a little bit of information, an introduction of SIM as an instructional tool. And so, let me see if I can advance. There we go. So I just wanted to start by sharing some photos here. This is actually at the SIM lab and a couple of the different locations where I'm teaching residents here and working with some of my fellow faculty. And I have many different photos here depicting what you can do with simulation-based education. You can see people providing back valve mask ventilations to a neonatal mannequin. You can see a multi-trauma mannequins in a multiple patient trauma scenario. We have residents practicing how to place arterial lines, and also mannequins that are being prepared to be intubated. And one of the things I want you to see from these pictures is how engaged those learners are. These aren't posed. Most of the time, they don't know that I'm going to snap a quick photo. And of course, these are all up here with these learners' permission, but you can see how they're really in the mindset as they would be at work, giving those commands, getting ready to intubate. And that's one of the features of simulation-based education that we want to impress upon you, is how engaging it is for our adult learners. So seeing pictures like this, you might think, wow, sim looks really engaging. If you look into a little bit more, you realize there's quite a lot of evidence for simulations used in medical education. There's evidence for improving knowledge and skills acquisition, patient harm reduction. There's actually quite a bit of robust return on investment literature in the area of preventing line-associated bacterial infections for hospitals that have a central line training program to reduce those bacterial infections for patients. There's a long record of simulation being used in high-risk fields like aviation, aeronautics, space, air traffic control, and any doctor would tell you that they would much rather practice on plastic and not the patient. But once you start digging into this realm of simulation education, you realize there's some challenges as well. First of all, there's quite a learning curve. Simulation educators have a lot of training and debriefing and in reflection on experiences and guiding people through those, almost like a cognitive behavioral therapist would. There's a lot of monies that goes into materials and the instructor time and training. So looking at this learning curve, it's understandable why somebody may be a bit intimidated when they're approaching simulation as an education tool. In this talk, we want to just go over some key definitions and some of the education theories that we think as educators you may be familiar with, and show them how they manifest in simulation-based education. We want to analyze some key considerations for employing simulation as an instructional method. And during this talk, we would like you to be thinking about how you can apply the knowledge here in your own context. How could simulation help you with in your own areas, whether it be protocol adherence or teaching a skill, how you could use simulation. In order to achieve those objectives, we're going to discuss those key terms, a little sprinkling of education theory. I realize I love education theory and not everybody does, so we'll keep that part a little short. And then also some learning applications for simulation and medical education and some key considerations if you'd like to get started using simulation. So starting here with a definition that I think is really important, and I was happy to see that Dr. DK also really liked this definition by David Gaba on what is simulation. So simulation is a technique. This is why I love this definition, is that it really, really, really underlines that simulation is a technique and not a technology. So it's a method. It's not just a piece of equipment. It replaces or amplifies real-world experience with guided experiences. These are those simulated experiences. They're often immersive, that evoke or replicate aspects of the real world. And that's when we talk about simulation's fidelity, its ability to replicate those aspects of the real world. So simulation's already used in a lot of different areas. The military and aviation, these high-risk fields where their performance is reliant on the performance of teams. These are areas where simulation is used quite robustly for training and for quality assurance. Some people are familiar with driving simulators in different countries as a way to learn how to drive, but medicine is using simulation more and more as an education and an administrative tool. A couple key terms that we're going to be using in this that I think it would be helpful for us to have some familiarity with. First of all, mannequin. Now, mannequins can be high technology or low technology. You can see here this mannequin, he's got some high flow oxygen on. You can intubate this mannequin. He breathes, he has heart sounds, he has pulses. But there are also low technology mannequins, which is kind of just like, you could imagine almost like a blow up doll where you can practice CPR on something that is as low technology as something that can just be inflated. So there can be high and low technology mannequins, and they can achieve different learning objectives. Task trainers, you can see down here 2 residents that are learning, helping each other learn how to perform a lumbar puncture. That task trainer just usually has a small part of the body. For example, a wrist with an arterial line trainer, or a small portion of the spine with a lumbar puncture trainer. And these are meant to just focus on that skill, whatever task is being trained. You have computer-based simulation, and here you see 2 of our residents enjoying a computer-based simulation where they're brought through a series of cases. That is a form of simulation. It is a guided experience. And down in the corner, you can see a standardized patient. And this is an actor who's been trained to mimic a patient They can be amateur actors. Some of these are actually professional, that they can be standardized patients for a living that work at a simulation center. And these are often used for, standardized patients are used for teaching history and basic physical examination techniques. So those are just some of those terms. Also, debriefing. After a simulated event, we will guide the learner through reflecting on that event. And there can be methods of guiding them that are very quick, like just a quick coaching at the bedside. Or you can actually sit down and have a whole debrief where it's a guided reflection. And this is something that simulation educators receive training in. Fidelity is another term that comes up quite often. And here I just have an example of high fidelity and low fidelity. Again, fidelity is that degree of realism, but you don't always need high fidelity in medical education to achieve your learning objectives. For example, the high fidelity mannequin above, it looks like a patient being ready to be intubated. And if I wanted the resident to put together their skills of safely intubating a patient in a high-risk scenario, that might be what I want to use. But this low fidelity model, you can see there's a marshmallow, there's some Twizzlers, it looks half edible. This model, although is very low fidelity and doesn't have a high degree of realism, still could have value if you were teaching somebody the anatomy that you need to know to perform a cricothyrotomy. So fidelity does not necessarily mean something is better or worse, having low and high fidelity. It just is the amount of realism. And often you don't need a high level of realism to achieve many, many knowledge-based learning objectives. Now on to what is one of my favorite parts. So I'll try to keep this interesting for the rest of you. Simulation is actually well-grounded in education theory. I have a few theories listed here. We're only going to go over a few of them because I think that they really highlight why simulation is so effective for our adult learners. And I'm going to start with adult learning theory. I said that our learners are adults. These are medical students. These are postgraduate students. These are faculty sometimes. These adults are coming to your educational experience with a lot of prior experience that's informing their decisions. They are self-directed and they want to solve problems with what they know. And they are, adult learners also have a lot of different needs. So the simulation environment really addresses that relevance by making an environment that looks like their workplace. They want to solve problems dealing with their workplace, and they're going to use their blend of skills, knowledge, and attitudes from a lot of other learning experiences to then manifest in maybe a clinical environment or use those that knowledge to try to conquer a clinical case and use all of those skills at once. So you can see how highly engaging this can be for an adult learner. Also, they get to bring that relevant previous experience and to try to solve those problems. And you can discuss that in your debrief, how that previous experience informed their behaviors when trying to conquer a simulated scenario. Next, I like to highlight Kolb's experiential learning. Now, Kolb, this really speaks to why simulation is, I'd say adult learning theory speaks to why it's so engaging, and Kolb's experiential learning speaks to why it's effective. So Kolb says that learning occurs from the examination of experience. So if you look at this cycle, it starts at the top with having an experience, then you reflect on the experience, you think about the different concepts that informed your approach to the experience and how you might need to rethink those or change those. And then you try to experiment, meaning reapproach the experience. So in the simulation lab, an example, this could be a simulation case where the learner is trying to figure out how to take care of an aortic dissection patient. Now, they're going to approach that patient and have an experience. After they make their decisions on how to treat the patient, I, as the faculty, will discuss with them how they approach that. Did you use the American Heart Association guidelines that we use in the United States? Did you call the correct consultant? And I will get that learner to really examine how they approach this. Once they are examining that, they can think of ways that they could have approached it better and ways that they could change what they're doing. And then maybe I let them do a similar but not the same case so that they can test and experiment. So this cycle and getting them to reflect in cycles and have experience in cycles is really what allows people to learn from this experience. So I think that this really speaks to why it's so effective. Lastly, these are my two favorite concepts for why simulation-based teaching really, really works for our adult learners and our highly trained learners. We know that learning works best when a learner is held in the zone of proximal development. And what that pretty much means is you don't want things to be too hard because they get really anxious. You don't want things to be too easy because they're going to get bored. They're going to start checking their email. They're going to start looking at their phone. So you want to keep them in the zone of proximal development. In the simulation environment, because you as an educator have so much control over the experience they're having, you can use the concept of cognitive loading to dial up the intensity or dial back down the intensity of the simulation in order to keep them in the zone of proximal development. If I am teaching a learner how to intubate and the learner is just doing so well, they're hitting all the learning objectives, and I want to keep them appropriately challenged, maybe I make that patient go have a hypoxic episode once they're intubated and ventilated, and keep challenging the learner so that they find that learning session effective and relevant to them. So these, again, very well grounded in education theory. I think it is a highly effective, although initially challenging as an educator to master being a sim educator. But once you get the hang of it, I think this is very effective for our learners. So with a little bit of that information to tell you why simulation is effective, we now want to talk about how it's being used in medical education today and a couple different points for how to get you started in incorporating simulation into your own practice. And Dr. DK, I'm now going to turn it back over to you.
All right, thank you so very much, Dr. Rice. And so just picking up from there, we're going to be talking about how simulation is being applied today in medical education. Like a couple of, almost a century ago, someone said that there is no excuse at that time to learn on a patient. And so you can imagine how much more appropriate it is today than it was in 1927 when it was first said. You know, and in medical school, I do remember when we talk about Osler, and Osler was one of those people who taught that the bedside was the best place, you know, firsthand for students to learn from the patients. Simulation takes that one step higher than that and just says that now we want to bring the learner to the bedside, prepared and able to engage with that experience. And so with that said, we'll just move on to some applications as it is today. Now, it can be broadly applied, as you can see here, but this is not even exhaustive. And so I have used it even to span from applied basic sciences to clinical knowledge. And then you can follow the decision-making process of your learner in a scenario, for example. It could also be used, you know, if you work in a team or multidisciplinary setting to cohese your team, just to see how the team works together or communicate. Say, for example, in emergency medicine, we do run codes, and it's multi-special. You do have a lot of multi-special specialties involved. And so this is one of the places that you really can use that. Also, of course, most of us have used simulators or task readers. My students enjoy every time we bring out the arm to do a venipuncture or a lumbar puncture. And so procedural skills is really, really known within simulation to practice skills, and we'll talk about that. Adherence to protocols, I think I heard Dr. Rice talk about that. You know, it's if you work in a highly protocolized specialty like say anesthesia or emergency medicine, you want to use simulation to either teach or enforce an existing protocol, or if you want to change protocols as things have changed, you can use simulation to actually teach the new protocols or to enforce old protocols. But broadly, even more than that, you know, thinking about, say, during Ebola, or during COVID, more recently the COVID, we can use simulation to do disaster drills and just check and test our preparedness to see how our systems can withstand these pandemics or these epidemics when they do occur. And so we'll be looking at how, you know, to apply these. So these are just the application, the broad areas. And what I want you doing is thinking about, you know, like your own specialty. And we'll get to that. Just be thinking about your specialties and how you can infuse this. but to integrate, to incorporate this into your teaching practice, these are some of the ways to bring those applications together. So you do have a case-based scenarios. This is where you write clinical cases, simulating real life situations. And here you're able to follow the learner's decision-making, test their mental models or their clinical knowledge, and then just see how they arrive at diagnosis and just see how the patients, the students or the learners manage the patient. It's also a great place to see how the team works together. So many things under that list could be achieved in a case, and this is probably one of my favorite things to do. Dr. Wright, I always thought that I enjoy writing scenarios, and so this is a fantastic way to test many things in your learners. And then going further, the next one is on procedural skills. Is another way to bring together many components of the applications for your learner. And while alone, so you can set up the station standalone just to practice a skill, or it could be after a scenario. So you just run a scenario, say maybe in the example I'm going to give, students learning bradyarrhythmias, and then you want them to do a transcutaneous pacing afterwards. And so either you do that as a standalone or after a scenario. But then these stations could be used to practice whole skills or the whole procedure. But I think the one I prefer the most, particularly for younger learners, is the ability to break down your the procedure into components of its task and just let them learn and master each component. And so I really love this about procedural skills. Now, moving on, we can also use simulation is excellent for teamwork exercises, teamwork and communication exercises beyond just the walls of a hospital. You could do this, like I said, in disaster drills. You could do it for preparedness. However, one of the ways that I found this also interesting is because I've worked in a military setting before, and in those high-risk teams where you require high-level coordination, it's one of the things we say in the military, or then at the time, was that if you work in a team, you practice with it in a team. And so medicine we apply the same thing. So I wanted to think about your specialty. Even though we're in specialties, we do work with other people. And so it's a nice way to have your nurses on board, to have your pharmacist on board, to round together and just see how this team works together. During these exercises, you can test the clinical knowledge as well, decision-making, all of the things in the application. But more importantly, you want to see how the team communicates and coheses together. Also in the area of exercises, one of the most interesting things I have done, you can go back to the slide before, is on for those in public health. I have used a tabletop, we have tabletop simulations where you can gamify the exercise and just, we simulated if there was an outbreak, what will you do? In emergency medicine, we use things like Sim Wars, or Surgical Olympics. It's fun, and it's also a way to kind of like see how your team works together. Finally, on the, how we can use just bring together those applications. One of the things, the last things I want to mention here is on debriefing. And for us in in simulation, medical simulation, debriefing is actually where the reflective learning happens. It's one big step that we cannot, overlook when we design our activities. And there's going to be a different talk about this in a subsequent session. However, just bringing it here is to say that in these sessions, you want to discuss clinical knowledge. You want to unpack the decision-making process of your learners. In the case of, maybe you just run a scenario. So I have had a scenario where one of my learner groups they did the right action in the scenario. Say, for example, they did not give a nitrate in a right-sided myocardial infarction. However, during debriefing, I realized that when I tested the mental model, about to, give them a compliment for not doing that, I realized their reasoning was wrong, and we had to address that in the debriefing. So really excited that's one of the places to unpack the decision-making process of your learners. Now, with all the things I said, I want you to just pause a little bit and probably just in the chat box, put there, just let's see, how would you apply, based on everything you've heard to this point, simulation in your specialty? I want you to look at just all the applications that we put up before, and just see, how would you apply this in your specialty? You can just let's recap that slide for them again, just so they can just look at that. Oh, awesome. So particularly, I'm curious about those who are not in, specialties that are currently heavily using simulation. Which of these applications do you think you would like to bring on and use? I just want you to think about it. You can drop down the chat box as we go along, and we would address them probably towards the end. Now we can just move on to, I love that I can see some chats, some things coming in already. And I love that you're thinking beyond. I love someone says it's all of them, right? All of them. So but I want to see what the radiologist would think about. And it's just exciting to think about what radiologists or dermatology and how can you use this. All right, so let's just move on to the key considerations when you're thinking about incorporating simulation into your teaching methodology. And just key things to keep it simple, I will be highlighting an example in my own practice and a scenario that I have designed before, just to see how we took these considerations and apply them in our design. So 3 questions you're going to ask yourself. Is simulation appropriate for what you're trying to achieve? Number 2 is, what resources do you have? And how is learning going to happen? Just think about these 3 questions, and we'll highlight each of them and delve into them quickly. All right, so is simulation appropriate? Like for every one of us, for those of us who have, who are interested and excited about simulation, we're excited to just jump in and use it for everything. But the question we have to ask is, what is it for? Who is it for? And what do you want to test, evaluate, or teach? And so diving into this, just one by one, we're going to go into each of them. And the question will be, what's it for? Just like you would do for any problem you're trying to solve, you're going to do a needs assessment and do a gap analysis. Is there a need? Is there a need for this activity you're trying to design? And just like you would do for any curriculum design, right? And there are methods to do this. The most popular is the Kearns method, for those who want to go study them. Now, if you find the gap, and then you set objectives to say, okay, what are we trying to achieve with this gap? And what are we going to do to bridge this gap that we just found, or the needs that we just found? And finally, you ask yourself, are those gaps really amenable to simulation? What I mean by that is simulation the best medical educational method to use to achieve those objectives that you have set? So sometimes our learners or faculty will come to me and, we want to do this simulation. And then the gap is actually a knowledge gap. And so I would say this is where you go back and have a session, a didactic session, a tutorial, a video, something ahead of time, right? And sometimes it could be a translational problem. And so that's translating to the bedside. I will tell you, go to the bedside as well and, help the learners at the bedside. But if any of these, if it's neither of this, then you can say this is amenable to simulation. And that brings us to the next question. Who is it for? This is where you are considering the groups of learners. Like, this is where you want to ask, who is this designed for? And what's the level of their experience and their practice? Because this would determine how you dial up or dial down the degree of difficulty. And just like Dr. Rice was talking about the zone of proximal development, you don't want to give a super uber easy scenario to a resident who just will be bored, or a medical student, what you will give to a resident, and they'll be so anxious and hate simulation forever. And so you want to make sure that they're within that proximal degree of proximal development. And so defining clearly who your level of your learners are. One last thing on this is to decide whether this is a single specialty or you want to do a multi-specialty, multidisciplinary approach or simulation. Now, last thing to consider in the area of asking yourself the question, is simulation appropriate, is that what do you want to teach, test, or evaluate? Simulation is one of those, is the method that I've enjoyed the most that can bring together cognitive, psychomotor, and behavioral or affective learning domains. And so you want to decide what you're trying to test here so you can amplify that. So just to give the example of what in the scenario I talked about, the gap analysis we did amongst a demographic a couple of years ago. We did this study amongst a demographic of junior doctors, right? And we found that peri-arrest was a problem. And so we designed a scenario. I want you to just put your focus on the highlighted parts. We were able, based on the needs assessment, we're able to define what this course is going to be about. We were clear about who the group of learners are. While this was designed for medical officers, we upgraded it and increased its difficulty for residents, and it was for teaching. So the activity type was for teaching. And then we went ahead and designed the goals and objectives we wanted to achieve with this. And so looking at those goals and objectives, very actionable. For those who want to know, we use the Bloom's taxonomy to define, these learning goals. But at the end of this, we knew we were going to do a practice on transcutaneous pacing, which, brings us to the next thing we're going to ask ourselves about, is that, do you have, now that you've listed those objectives, what resources do you have? And here you're looking at equipment. I want you to not think technology, think equipment. So do we need an IV access? Do we need a pole? Do we need to set up a room like an ER or an OR? And also you ask yourself, what faculty, do we have enough faculty trained in simulation? I'm super excited because you're here, and it means that you are going to be that faculty for your specialty, right? To get this going. And so, but more than just the faculty skill is also the availability. Simulation is a whole rodeo on its own. It's a whole production. And so we want to be sure that you have protected time. And finally, on this, you're going to ask yourself, where is this going to happen? So the venue, not just in terms of space, but also decide, is this in person, is this virtual, or is it a hybrid? And because it will determine the degree of participation of your learners. So while your learners could be 15 in a group, only 5 can be in a scenario, for example, you need to think ahead, where are the 10 going to be, and where are they going to participate and observe this learning activity? All right, so just looking at that is just going to share with you again what for the same scenario, we brainstormed everything about the room and equipment, and then we went ahead to define whether we would need a faculty and block out their calendars on the slide. You can move on to the next slide. And then we needed a standardized patient here, so we requested for one. And then the teaching methodology was mannequin-based scenario and a standardized patient. Oh, excuse me for that. All right. The last question we're going to ask, while considering incorporating this into your learning, into your teaching methodology, is how is learning going to happen? Because all of the first 2 questions were to set the stage for this to happen. And here, this is when you design the activity, the simulation activity, whether it's a scenario-based, a procedural skill, or teamwork. This is where you design, and then you think about, how am I going to deliver that activity? And of course, debriefing. And so just talking about the components of simulation activity, you will hear us talking about pre-briefing, the scenario, debriefing, and then an opportunity for repetition. Just to quickly just mention about pre-briefing is everything that happens before the actual simulation. And so you're looking at, so prior to the day of the activity, you don't want your learners coming into the simulation blind. We don't want them guessing what they're going to do today. So everything you've done, either it's a pre-read you've given them ahead of time or a tutorial ahead of time. But however, when they show up on that day, you want to make sure that you have given them enough information about this, and you set the stage on that day. You want them comfortable, giving them psychological fidelity or psychological safety. You also want them to suspend disbelief and just make them feel like, if this is set up like your, say, an ER or emergency room, and you tell them, act like you would in your normal capacity. However, if there's anything you don't want them to do, this is where you tell them. I wouldn't want them sticking a needle in the chest of my standardized patient. So I will mention that here. And then you allow them go into the scenario and then debriefing. Just the last thing on this slide is to talk about the fact that when I'm designing a scenario, I'm thinking that my scenario, my debriefing must be twice the time I give for my scenario. So if my scenario is 5 minutes, I cannot debrief less than 5-10 minutes. Some would do 1 to 3, because remember, that's where the learning really occurs. And so just a sample scenario based on the same example I've been given this is what this looks like. And so you're looking at this, the overview, this is what you as a faculty will get, is the overview where you have the back end story and all of that. But the synopsis is what the learner gets. Here, in this case, is a 67-year-old man with altered mental status. And you watch process as they arrive at the diagnosis, giving them prompts as they go. This was written as just with critical points. However, you will find that there are flow sheets. When you go to other scenarios, you would see a case flow sheet like this, which often includes vital signs and some anticipated actions with branch points. So if the learner does this, this is what's going to happen. And then you change the vital signs as they go. However, as the learners get more advanced, they could do something totally unanticipated, and you want to be ready for that as well. But this helps you and guides you along the way. Wow. So, I mean, I know for some of us who are really excited about, simulation and curriculum design, we get on and on, and I could go on and on about simulation design and scenarios but then it could be intimidating for you if you're getting started. Not to worry, there are lots of peer review cases and just open access cases that you can use, plug and play, contextualize. That is, you can take any of these, contextualize it, and then use it in your scenario. Well, Dr. Rice and I were emergency physicians, so we had access to these ones on the screen are emergency medicine, but I want you to choose your specialty and go look for them. They will be there. There'll be some available. And as you progress in simulation, you're able to write your own scenario as well. And then some mentees and I are trying to put together one that is more appropriate with similar names like we will see in our environment. And we're hoping that maybe as we get along, some of you will come on board and we can write contextually relevant scenarios as well. So no, not to worry, find your own scenarios. Now what? Now for the past probably 30 minutes, Dr. Wright and I have been getting you, we hope we've been able to get you excited, just like we are about simulation. You should see us, just going back and forth about this. You can tell that we really love this and it really excites us. But then I want to throw it back to you. Now what? We've piqued your interest now, and while there's still so many things to learn about scenario writing, doing a needs assessment or how to integrate this into a broader curriculum, I want you to think about your own specialty and just think about how would you contextualize this or integrate these techniques into your own clinical teaching environment. And so I want you to begin to think about, brainstorm the possibilities. In the chat box, I can see the chats coming in and people are already thinking about how to use this in their different specialties. So this is now in your court to say, brainstorm all the possibilities. Medical education landscape is changing and there's so much exciting things ahead. Just think about how this could also add to that excitement, but also to dial it down to our own context and in Ghana and in Africa. Just think about the hurdles. What are some of the hurdles that you would also have? And then just begin to brainstorm solutions on that. Right. Well, we'll be happy to take your questions at the end of all of this. I wanted to leave you with 3 key takeaways. Simple to know. If this is all that you can remember, it will be very happy. Number 1 is that simulation is a technique and not a technology. It's a technique, not a technology, and it's broadly applicable. While we've covered only a few here, there's so many things you can use it for, I promise you. And finally, if this is the only thing you remember today, I want to leave this with you to say simulation enhances your clinical experience. It is not to replace it. And so that's how I wanted to think about all of this, that how can this enhance the clinical experience of my learners and not replace it? Thank you so very much. And I will be looking at the chat. Dr. Rice and I will be happy to answer any questions. And just to let you know, there are simulation centers popping up around Ghana, and there are people to just ask for help if you're already getting excited about this. So thank you so very much. And over to you, Dr. Professor Laura. Thank you so much.
Thank you to our wonderful presenters for such a great session. I'm seeing a whole lot of engagement around ideas in the chat as to how people could use this, from acute poisoning scenarios to mass casualty to surgical skills to communication skills like breaking bad news, all of which may be tremendous uses of simulation. If we want to give people just a moment to see if anyone wants to drop anything into either Q&A or the chat, we will. And if folks want to take a moment, there's a link in the chat for an evaluation form for our presenters, which will also ask you to identify your own goals around simulation, so that we can continue to work with the Ghana College to make sure that you have the resources and training that you need in order to be successful in this domain. And I am also going to drop on a quick QR code that if it's easier to grab the evaluation form that way, feel free to utilize that. Do any of our panelists have thoughts about or questions about simulation while we're here? Dr. Reindorf, Dr. Lawson?
Yes, a few. I mean, Dr. Rice and Dr. Nkechi have done great justice to the subject. They are whetting our appetite to do more. Certainly, we need space, we need the mannequins, even though they've told us we don't necessarily need high fidelity. But I mean, in what they've described, we are capable of doing a whole lot with what we have. So I can only say thank you to them for this exposition. Thank you.
Okay, and I'm seeing a relatively quiet chat. So if people want to take a break for about 10 minutes, we'll reconvene here at 1 o'clock for our next session, which will have to do with concepts on assessment and evaluation. Thank you both to Dr. Rice as well as Dr. DK, and I just saw Dr. Lawson unmute. Welcome back. It gives me great pleasure to introduce Drs. Ritter and Regan from Johns Hopkins University, and Dr. Okosua Asidu-Asante is also going to be assisting them as well. I'll let you guys do your own introductions.
Hello, great to be invited to talk about something that we love to talk about. I'm Linda Regan, and this is Catherine Ritter. We're here together. We have a member joining us who's going to help facilitate some crowd activities. We're going to talk to you about assessment and evaluation, which is a very broad topic and is a topic that I think it can be easy to think that you know a lot about if you don't actually know the details around the differences between assessment and evaluation. And so up until, a number of years ago, when I formally learned the differences between assessment and evaluation and the different types of assessment, I really didn't have a great understanding of what the differences were. And I think that when you have a better understanding of why there's a difference and how the differences affect how you use the different types of assessments and evaluations, it really allows you to be a better teacher and to allow your learners to be better learners. So we're going to be talking about the difference between assessment and evaluation. We're going to talk about how they're different and how there's different types of assessments. We're going to talk about the importance of the formative assessment in your learners and their development and their progress. And we're going to talk about some specifics about formative assessments that you can use in different situations. So this is the outline we're gonna go through, and we're going to start just jumping in and telling you about some definitions. So what is assessment?
Okay, so hello guys, I'm Akosia. I'm an emergency physician and I'm assisting Catherine and Linda with this assessment. At this point in time, I want you to put in the chat group how comfortable you are with assessment or assessing your students when they do procedures or when you teach them. So 1 being the least comfortable to 5, which is being the most comfortable assessing your students. We have a few seconds. If you could kindly put your numbers in the chat for us.
All right, we have a couple people throwing some numbers in there. So some people feel really comfortable, some people are less comfortable. So this is a great way to assess the room that you're going to be talking to or the learner group that you're going to be teaching. And if we could see you, we could ask you to hold your hands up. And so just looking in the room or looking at the audience, you could see immediately that the room was rather inexperienced or rather experienced. And if you're on Zoom, such as we are here, you can simply have people throw their answers into the chat. Or if it's a small group, you can have them say them out loud. But on Zoom, if we could see you, you could just hold your number up with your hand and we can get an idea based on how many fingers, how comfortable or how experienced the room is. And the reason that's important is because then you, as the person who is targeting your teaching to the group of learners have some understanding now of the range of experience of your learners. So that's what assessment is. And I think it's pretty simple, but it can feel very complex. So assessment is essentially a process that allows us to facilitate learning, and it allows you as the teacher, as well as you as the student, to know where you both are. So if everyone in this group put a 1 into the chat or held up a 1, I would know that this was a rather inexperienced group about understanding assessment and evaluation. And I would target how I would teach or what I would say to a different level than if everyone put a 5 into the chat, where we'd have a much higher level conversation because the basics already perhaps were known. Now, there is the possibility that people are self-assessing incorrectly, and they may say they're either better or worse than they actually are, but getting an understanding of the comfort level of your group before you teach them or you ask them to do something, like as Dr. Rice just talked about in a simulation, allows you to really target the appropriate level of teaching for that learner. So assessment is systematic. It's not something that generally just happens off the cuff, although it can feel like that sometimes. And it is supposed to involve multiple sources to allow you to make an inference or make a decision about where you believe that learner is in the process of their learning. So what does that mean? It means that I think when we talk about learners and say, oh, we're going to do an assessment of your ability to suture, learners are nervous, right? It feels like they're being tested. Oh my gosh, like, am I going to pass? And I think that when we think about assessment versus evaluation, assessment is really a process that allows you to learn and hear if you're progressing appropriately on the scale of learning, as well as allow the teacher to know whether or not they are teaching appropriately. So if they do an assessment and no one knows how to do it, no one can suture appropriately, it's potentially that the problem is with the teacher and not necessarily with the students. So assessment and evaluation are probably the most confused terms in education, where people say one and mean the other. But the easiest way to think about it is that assessment is about growth of the student or the program, and evaluation is a judgment. So assessment is so that if I want to understand how you're doing today, I can give you information so you can be better tomorrow. That's assessment. That's for growth and progress. Evaluation talks about, have you learned the material and can graduate from the program? Are you able to become board certified? Was the program adequate to meet the needs of your goals? So for instance, you will all be completing an evaluation of the program that we are doing here, as opposed to doing an assessment.
All right, next we'll go into the differences between formative versus summative assessment. So first we'll start with a brainstorm. Some of you may be familiar with these terms, formative versus summative assessment. For some of you, they may be completely new. So just take a minute to think about what those terms mean to you. And if you want to write them down or if you want to enter them into the chat, that would be helpful for us to see if this is a new concept to all of you, or if a lot of you are already familiar with formative versus summative assessment and what their differences are. So we'll just take a minute to do that. And that's okay if this is something that's new to all of you, since we're about to dive in and learn more about what these differences are. So I'll just go to the next slide here. So formative assessment is something that should be low stakes versus summative assessment is more high stakes. So formative assessment is assessment that occurs during the teaching and during the instruction. So depending on what your context is for teaching, this may be something that you do in the middle of a lecture with a large group of students, where we're asking questions like we're asking right now to gauge what the students' current levels of knowledge are, what they know about a topic versus what they don't know. This is something that is very low stakes. This isn't something that is going to go into the grade book by any means or determine their final grade in this course that you're teaching. Whereas summative assessment is something that's high stakes and typically occurs after the instruction occurs. So you're wanting to see if the students have learned what you were intending to teach them during that course or during that clinical rotation. So we'll dive in a little bit more about these details just so we can get more familiar with the differences between these two topics. So formative assessment has two big goals. So it's going to improve your teaching as an educator, but it's also going to improve the students' learning as well. So this is something that's conducted throughout the term or the rotation that the students are currently on if we're talking about teaching in the clinical setting. And this is really part of the learning process where the students are able to kind of put themselves out there and say, do I know the answer to this question or not? And get direct feedback from you as their instructor about what went well or what is something that they need to keep working on and keep learning. And then for you as the educator, you can really see where your students are at and say, okay, maybe I need to slow down and spend more time diving into this topic. Or maybe your whole group of students that you're working with in your clinic that day already knew the answer to that question. So you can move on and dive into some higher level concepts for them so that you're teaching them at an appropriate level where you're challenging them to keep moving their knowledge forward and not telling them something that they already know, but you also don't want to breeze by a concept that nobody fully understood. So it's beneficial for both you and the student. So then, because the students are being frequently assessed throughout these formative assessments, it's really assessment for their own learning so that then they can go home after that day in clinic or that day in the operating room with you and say, I didn't know the answer to those questions. I need to read more about this topic. So it really assists in their own self-directed learning where they can help identify where their gaps in knowledge are and what those important gaps are that they should spend additional time studying. And then, like we talked about, this is going to really assist you as the instructor where you can modify your teaching plan based on what people know or what areas they're less comfortable with. And then contrast this with summative assessment, which I think is what a lot of us first think about when we think about summative assessment. We're thinking about those grades that get entered in the grade book at the end of a course or at the end of a clinical rotation. So this is an assessment that we're doing at the end. It may be a written test. It may be a clinical grade based on all of the performance that they had throughout the entire rotation with you. And this is something that's really meant to assess, did the students learn what we were intending to teach them when we set out and designed this course or we set out and designed this clinical rotation? And this summative assessment, it's going to be very comprehensive. So it's going to cover a really broad sample of all the objectives and all the learning goals that we set out when we were designing our curriculum for these learners. This is a helpful analogy to try to keep these two concepts separate in our minds, where when we're thinking about formative versus summative assessment is when you're the chef, you're preparing a soup, and when you taste the soup to see how it is. This is what our students are doing when they're getting these results of their formative assessments. So they still have time to modify and change things before the summative assessment at the end of their rotation, where now instead of them tasting the soup as the chef, the guests are going to taste the soup. So we've had all of this feedback that we've gotten through our formative assessments to keep improving the soup so that it's ready for dinner time when the soup goes out and all of the guests are going to try it.
Okay, so we're going to talk about some key principles, and much like the first talk with Dr. Rice, we're going to talk a little bit about some learning theory and some understanding of why feedback works when you do it certain ways. So, I'm sorry, why assessment works. So the first thing to think about is that learners, as Dr. Rice said earlier, are adults. We're dealing with, people who are medical students or in residency or faculty, and they are going to be goal-directed to improve based on things that they view as important. So the assessments that we're talking about, in particular for formative assessments where you're hoping for growth, really have to be directed towards a certain goal. And that should be feedback, as Catherine talked about, that is really important both to the student and to the instructor. So how can you ensure this moves forward successfully? Two important things to think about. One is motivation for adults, and two is making sure, as I said, it's goal-directed. So what motivates adults? Two big things. One, learners are not going to be motivated to move forward or to try to learn if they don't think they're going to be able to do it. So as you heard earlier, and we'll talk about again in a couple slides, this idea of the zone of proximal development, where if you push learners too far past what they are capable of, they're not even going to try because they don't believe they can be successful. In addition, it needs to add value. So as adults, we have only a limited amount of time to learn or to grow or to decide where we're going to focus our attention. And if we don't see the value in that topic, you won't be motivated to go ahead and move forward. So when we give feedback based on assessments, those should be focused at making sure you have very clear understanding for your learner about what the goal is for them to improve. In addition, you should help them understand how they can practice so that they can improve, or how they can read so that they can improve, or how they can do another simulation so that they can be better at intubation or better at a procedure. And this allows you to not just give the answer of the assessment, how did you do, but it allows them and encourages them to take time to practice so that they can see the path forward to how they're going to learn and improve the best. So you'll have a session coming up after this about feedback, but the thing to, I'll just throw out there that the reason formative assessment is so important is because it allows you to give feedback to someone in a timely manner that is based on data. And as we just talked about, has the ability to put a roadmap in front of someone to say, okay, you couldn't do this. You couldn't put a suture in appropriately. You agree that you couldn't do that because you watched yourself not be able to do it. And now we're going to talk about what are the steps that you can do to be able to do better in the future. And that leads us directly into the topic that was introduced in the prior session, which is the zone of proximal development and this idea of scaffolding. So zone of proximal development, you've already heard about, but it's basically this idea that if learners are pushed too far past where they are comfortable or able, they are not going to be able to do the task, and thus they may not be willing to try to do the task. So think about a little kid trying to learn how to ride a bicycle. If you take a 3-year-old or 4-year-old who doesn't know how to ride a bike and you put them on the bike at the bottom, they're likely not going to be successful. They do not have the balance to be able to be successful. They do not have the motor coordination or the ability to understand how to steer appropriately. And so that's why when you're thinking about what is the first thing that someone who doesn't know how to ride a bike should learn how to do, you think about the picture at the top of the screen. This is a balance bicycle, right? All this is, they can put their feet down on the ground and then they can just pick them up and learn how to balance on the bike. It doesn't involve pedaling. It doesn't really involve steering. And it's very, very close to where people feel comfortable, right? And then, past that, maybe you have training wheels or someone holding the back of your bicycle. And then past that, you can be competent to do it independently. So what did we just talk about? We talked about this concept of chunking or of creating a scaffold or a framework for someone to be able to see how they will get from point A to point B. So the goal of your assessments should be to say, okay, if I want someone to be able to ride a bicycle, what are the actual steps that need to happen for them to be able to learn how to ride a bicycle? They need to be able to balance. They have to be able to turn, have motor coordination to turn the front. They have to be able to pedal. And if you can decide what those steps are, you can create discrete small topics that people can work on individually. So for instance, someone who's learning how to suture crosses various disciplines. The first thing that you may do is just control of the instrument, right? Before you say, okay, load your needle driver, put a stitch in and tie it, maybe the first thing you do is to do an assessment on, can they hold the instruments correctly? Are they appropriately able to use their wrist in fluid motion? And you're not asking them to put a suture in and to do a tie, because that's multiple steps far in the future that if you haven't yet trained them for that, they will not yet be able to do. So the goal is to break things down into small steps. Perhaps those steps are instrument handling, and you do an assessment and give them feedback on that. And then you let them practice again. The next step may be suture position and placement. And then there's an assessment and they get feedback on how they're doing. And perhaps the final chunk or discrete topic is the tie of the suture, whether or not it's a hand tie or an instrument tie. And then they have assessments that give them feedback so that they can work and progress to have a better level of performance at the end when you do your summative assessment. And that is this idea in medicine and medical education, where we use checklists or structured evaluations or assessments to say, yes, you can do the top 3 items, but where you really need to work on are these bottom items, right? You shouldn't expect that someone can do step 5 of a procedure if they still have not shown to you they can do steps 1 through 4. So I like to think about sometimes the best ways to be successful are to know where your pitfalls are. And so the most important pitfalls that I want you to take away are, 1, when you have assessments, to understand and emphasize very strongly that the feedback you're getting based on this assessment is not the end. This is just the beginning of time for you to be able to practice and try again. And if you as the teacher make people do their final summative assessments before they've had the opportunity to practice and try again, then you have not done them justice in giving them the time to build and grow from the formative assessment. And then lastly, as we heard about in the simulation talk, this idea about as a teacher to be very clear about what it is that you're hoping for people to be able to do on their assessments. So if I don't tell people I'm teaching them or expecting them to learn how to suture, but I'm expecting them to arrive and learn how to and know how to already do it, that's clearly going to set people up for failure and not set them up for success.
All right, now we'll go through some formative assessment tools that hopefully you all will be able to take into your own clinical practice. And as educators, we may teach in a very wide variety of environments. Sometimes we may be teaching a large lecture hall full of students. Sometimes we may be working with small groups in a didactic setting, or sometimes we may be working in the clinical setting with maybe only 1 or 2 trainees. So we're going to talk about different techniques that you may use in those different settings. And this is a very broad overview. So hopefully there may be 1 or 2 things that you can take away from this and look into more and think about how you may be able to incorporate that into your own practice. So first, we're going to start with formative assessment tools that you may use in that formal didactic setting where we're thinking about this large lecture hall full of students or a small group didactic setting. So just thinking about our talk that we're doing here, which even though we're doing it virtually over Zoom, I'd say this is most similar to a large lecture hall where we're teaching and there's a very, very large number, over 100 group of participants in the room here. So what tools can we incorporate to help get that information and think about where people are at and what we maybe need to spend more time on, what we want to teach our audience. So we did do some brainstorming earlier when we were thinking about what some of the differences were with formative versus summative assessment. Hand raising can be asking your audience to raise their hand about topics that they would like to learn more about or topics that they're unsure about. Or it can be something like the 1, 2, 3, 4, 5 that we used earlier. And if you're in a virtual setting, you can pivot and do entry of a number in a chat if you can't see your learners, but that can be a helpful way to assess their comfort level with a particular topic where they're self-assessing themselves on a scale of 1 to 5. And then in virtual settings like this, sharing ideas in the chat can be a helpful way just to assess where your group of learners is at and how you want to continue teaching the content that you've already planned to include in your talk. When you are going to teach in this didactic setting, it can be helpful to do a brief pre-knowledge assessment. And the goal here would be for it to take a pretty short period of time so you're not cutting into the rest of the instructional time that you have. But as an educator, you can really gain a lot of helpful information by just incorporating 1 or 2 of these into your educational practice. So asking your learners to brainstorm about the topic that you're planning to cover that day. You can also develop a quick clicker poll. There's clickers that you can use, but then there's also ways to turn other devices into audience response systems too, so they can be essentially functioning as a clicker for learners to share answers to questions or self-assessments of their own comfort levels with different topics that you're planning to cover. We also talked about hand raising to show interest or self-reported comfort or confidence. And then you can always do a quick starter quiz on pen and paper too, or a quick pre-test just to see where everybody is at to assess their knowledge before getting into your topic for the day. It's also really helpful to do a brief assessment after you have gone over the content that you're hoping to cover for that day. And you can use similar strategies where you can have people brainstorm. Maybe you're asking them to apply what you have talked about throughout the course of the day to their own setting. So maybe you were teaching them certain techniques. I know when we were talking about simulation, someone put in the chat the idea of breaking bad news. So if you go through an educational session about that, maybe at the end you could have them brainstorm what they are going to do the next time that they have to do that in the clinical environment. That can just be a really good way to make the knowledge meaningful to them, and they can think about how they're going to take that knowledge out of the didactic setting and put it into the clinical environment. You can also develop a question where your students will write a 1 or 5 minute paper, and the picture here shows an example of something you might go into, which is what's the least clear point that we went over during our session today? Or it may be something that they're hoping to read about and learn more about related to the topic that you covered. So there's really a wide variety of topics that you can cover in that 1 or 5 minute paper, but the actual act of asking students to write that down and put something really makes them engage instead of maybe just breathing through something and not necessarily committing to something that they're going to apply to their practice or something they're going to go home and read more about. And then you can also do a clicker poll at the end of your session, just like you maybe did at the beginning of the session, in order to now assess if your learners were actually able to take away the knowledge that you were hoping that they would take away from their session. And the benefits of doing these types of assessments at the end of your session, especially if you're involved in a longitudinal course or rotation, is that if there are things that come out of your 1 or 5 minute papers where things are not as clear as you were hoping they would be, or maybe when you look at the percentages of students answering questions correctly on your clicker poll, if they weren't where you hoped they would be, that can be a cue to you that you maybe need to go back and spend more time the next time you see those students, just clarifying any of those points that weren't clear, or explaining those key concepts in a different way that maybe people weren't able to absorb by the end of your first session. Here are just a couple examples. You can find a lot of examples of these tools on the internet, and you could just use them in your own educational settings where they sometimes have all of their questions already written out for you. So here's just an example of something that might be like an exit ticket for students to write down the answer to these questions before they leave the room that day after you give a lecture or you work with small groups. So asking them what the most important thing they took away from class was, if there's anything they're still confused about. And then it's also helpful to have them rate the pacing as well, because as the instructor, that can be really helpful for you just when you're thinking about what modifications you can make to your own teaching to make sure that your course or your curriculum is achieving all the objectives that you initially set out to achieve. Here are just some more specific pictures and examples of what we talked about. So here are the audience response clickers, but you don't necessarily need to have these fancy clickers. A lot of times there's ways to have students turn their own devices into an audience response system just using platforms on the internet. One such example is Kahoot, which is a fun game to play with your students. So in this game, you can get it online and you can enter all of your questions into a Kahoot, and it can either be knowledge-based questions. You can also ask students to rank things or give their opinions in Kahoot as well. And then on your end as the instructor, what will show up is you'll see what the responses are. You'll see how many students answered. You'll see how many people chose each specific answer choice. So for our talk today, a question we might ask is, what formative assessment tool would you like to learn more about? And then the students on their own phones or other electronic devices can log in and choose which one they want to learn more about. And then for you as the instructor, you would be able to spend more time on that specific topic or that specific answer choice that students were looking to have more time spent on. You can also integrate polling questions into your Zoom presentation as well. And this is really handy because it's just at the bottom of your screen here, as we highlighted in this slide. You can open up a poll, have people respond, and then the results will show immediately into your presentation. So sometimes it can make things a little bit easier on your end as a presenter, so you're not flipping between multiple screens when you're trying to share your desktop as you're doing a virtual educational session. So then now just opening it up to you all if you want to enter your answer choices into the chat here based on what we talked about here for formative assessment tools that you can use in didactic or small group settings. Which of these do you think you'll plan to use the most when you're thinking about your own teaching environment? Multiple choice quizzes, audience response systems, using clickers, or potentially other audience response systems like Zoom polls or Kahoot, hand raising, essay and writing assignments, or some 1-minute papers. So I'll just give you all a little bit of time to think about that as you're thinking about your own teaching environments. All right. Now transitioning into the clinical setting. So we'll talk about formative assessment tools that you can use when you are working with students in clinic, in the emergency department, in the operating room. And we're going to split them up into 2 different categories because I understand that there's many different clinical settings that you may be teaching in, and sometimes you will be teaching students via indirect observation where they may go see a patient, come up with an assessment and plan, and then present that patient to you. So you're observing their clinical skills in an indirect way versus direct observation where you're going into the room with your trainee, watching them collect a history, watching them do a physical exam, watching them do a procedure. And the formative assessment tools will vary based on what type of observation you're doing. So we'll first dive into indirect observation. So one specific way that you can do formative assessments with your trainees through indirect observation is through a case-based discussion. And depending on your workflow, this may happen at various times. It may be that you are now coming on to rounds after your trainees were on a call shift and they have admitted multiple patients and they're going to present all the patients on rounds the next day. Or it may be like in our clinical setting in the emergency department where it's immediately after the resident may go see a patient, and then we'll see it during that shift. So shortly after they've seen the patient, and we're going to talk about that case. So what's helpful for you as an instructor to do is to, if the resident or the student has done any documentation in the medical record already, especially when we're talking about that situation where you're coming on for morning rounds and they've already had a whole night of admitting these patients, reviewing their history and physical, seeing what their diagnostic reasoning was as they were writing their medical decision-making in that history and physical note can be really helpful. And then when they present the patient to you on rounds or via their oral presentation, like in the emergency department after they've seen this patient, you can really assess the trainee's clinical reasoning as they're going through what their assessment is based on evidence from the patient's history, their physical exam, and any sort of diagnostic studies that have already come back at that point, whether you have the EKG, any labs, any imaging studies. And then you can really try to put those pieces of the puzzle together to see how your trainee gets from collecting that data to interpreting that data and moving forward to make a treatment plan for that patient. So that back and forth case-based discussion can be a time where you can ask some probing questions and ask them, why are you planning to order that test? What information are you hoping to gain from that? If the test result is positive or if the test result is negative, how would that change your disposition for the patient? How would that change what medications you're ordering? How would that change who you need to consult? So all those types of questions are having this case-based discussion. It can really help you see why the trainee is doing specific things in their clinical decision-making. And it can help you identify maybe the trainee wants to order a test that is appropriate, but maybe their rationale behind ordering it isn't necessarily putting all the pieces together. And you notice that there's a gap there that can be addressed. So this is where these case-based discussions, they're clearly important for patient care, but they can also be a really important way for you to assess your trainees as they are synthesizing all of this important data about the patients that they're seeing. Another thing that you can do in a clinical setting is very deliberate questioning. Now, in medical education, questioning is something that has been used for many, many years. So there are some learners who may get a lot of anxiety when you start pulling out multiple questions. So what I always like to do is expectation setting with trainees, especially if it's a new student on rotation that I'm meeting for the first time, and say, this questioning is important to help me learn about ways that I can best teach you and help identify where those learning points are, because you don't want them to feel like it's just a constant high stakes test when you're questioning them in the clinical setting. You want them to really have that buy-in and be engaged and recognize how this is important for their learning. So I think that that expectation setting can be really helpful when you're thinking about asking your trainees questions. The second point that I wanted to bring up with questioning is making sure you give enough wait time, because a lot of times it's easy to jump in if there's that silence, but letting that silence really just remain there for an extended period of time is important, because you don't just want to ask a question and answer it yourself right away. For higher order questions, it's important to wait at least 10 seconds, because you want to give your trainees time to acknowledge the question, synthesize everything that you said, and come up with an answer, especially when you're asking them to do some higher order thinking and analysis of labs and interpretation of imaging studies. You want to make sure you're giving them enough time to do that. And when you're thinking about the question that you want to ask, it's helpful to think about what you're trying to assess when you're asking that question, because questions can assess anything from your trainees' knowledge, skills, their attitudes, and you really want to be thinking about how that question is going to link to what you are directly trying to teach them. So being really intentional about our questioning can be a way where we can see where our trainees are at. They can also get some real-time feedback about areas where they should go home and learn and read more, practice some more skills the next time they come into the clinical environment. But this is a helpful way for them to think about what they want to learn, and also for you to help teach them too. When we're thinking about the types of questions, we can ask closed versus open-ended questions. A lot of times asking open-ended questions is going to be more helpful for you as an educator, because you'll really get to know the rationale behind what the learner is thinking, and you can really probe more about what their clinical reasoning and their medical knowledge is. You can also ask some simple recall questions, which is just rote memorization, or an analysis question that will be higher order and going into the pathophysiology of a specific topic. So something that would be a recall question would be just asking your trainees, what are the 4 different classifications of shock? Whereas an analysis question would be diving more into the pathophysiology and asking them to talk about what vital sign changes they're expecting to see based on the different types of shock that we're talking about. And then you can also think about fundamental or applied questions. So if you're on rounds with your trainees, asking a fundamental question, maybe asking a question that is fundamental knowledge, that is something that you would learn out of a textbook. Whereas an applied question is something that applies directly to the patients that you're seeing. So asking a fundamental question, getting back to that shock example, could think asking somebody what the pathophysiology is of the 4 different types of shocks. That's more fundamental, versus an applied question would be you saying, hey, let's look at this patient in front of us and all their vital sign abnormalities, and think about what type of shock we're seeing and why we're seeing different vital sign changes with their blood pressure and their heart rate changing, since we're talking about that direct patient in front of us and applying that knowledge from the textbook to the clinical setting. One other method that people have used for indirect observation in the clinical setting is something called the 1-minute preceptor, which is there's lots of papers and resources online about this, but just to hit the high points, it's essentially you're having a student or a resident give a presentation to you, and you are going to use that as a teaching opportunity to assess where they're at, and then also teach any important concepts that maybe have been a gap that you identified. So the most important steps when we're thinking about formative assessment are steps 1 and 2, which is you're going to get a commitment from the learner and probe from their clinical reasoning. So you don't want a trainee to just present a patient and tell you all the data, but not actually commit to a plan. So this is where, if they just kind of present the whole history and physical, but kind of taper off at the assessment, this is where you're going to get a commitment. You're going to ask them, what labs are we going to order? What imaging studies are we going to order? You're going to get that commitment from them. And then you're going to probe for their clinical reasoning and ask them why. And these 2 steps are where you as the educator are really going to get into the learner's mind and see what they're thinking and why they're thinking. And as you're doing that, you can see, okay, everything is adding up, or you may see there's some gaps that I need to address here. So this is where now you're going to jump into step 3 and teach some general rules about a concept that maybe that you recognize was a gap in their learning as you were going through the 1-minute preceptor. It's also a time where you can give feedback, which, like we've talked about before, is key to these formative assessments. So you can reinforce what was done well, and then also give some constructive feedback about things that they can change for next time. So these 5 steps, they don't take very long if you go through them deliberately, but it's just a good way to help incorporate formative assessments and feedback into a busy clinical practice. And that's why it's called the 1-minute preceptor, is it shouldn't be something that takes you 20 minutes to do. It should be something that is short, concise, and is really focused on just a couple teaching points for your learner after this patient presentation. So then now that we've covered some indirect observation formative assessments, we'll just hit some direct observation assessments. There are so many that exist out there, and there's a lot of resources online where you can learn more about specific direct observation tools that you can use for formative assessment. So for these assessments, we are going in with our learner, watching them do the full procedure or take a full history. So one example of a tool you can use is something called the direct observation of procedural skills, which is essentially a checklist that you're going to go through and assess the trainee as they go through all the steps of their procedure. The most important part of this assessment tool is that you debrief with them afterwards and give them feedback. I know we talked about debriefing in the simulation talk, but debriefing is so important because that's really where the learning happens. So I'll bring up an example of the specific parts of a procedure that you can do a direct observation for. So you can go in with your trainee as they are describing the indications for the procedure to the patient. You can make sure that they're able to identify the important anatomy, obtain informed consent appropriately. You can also watch them prepare and set up for the procedure, since a lot of times there's opportunities for improvement there, since trainees may be doing that with indirect observation for the most part, but actually going in there and directly observing them, you can learn a lot and help them really streamline that process. You can also assess the sedation or analgesia that they use for the procedure, their technical skills, their ability to recognize complications, communication, and professionalism. And these are just some examples here, so you don't need to watch every single step for every single procedure, but coming in with a really intentional focused goal can be important, because you as the instructor and then your trainee can know, okay, today is going to be a day that I'm going to be directly observed doing informed consent for a central line. And then you can debrief that afterwards and really help refine their skills in that process. This is just an example of a direct observation of procedural skills that I got off of MedEd Portal, which is a great resource for cases, for educational tools like this. So this is a direct observation sheet for doing ultrasound guided vascular access. And as the instructor, it's really helpful for you because all of the steps that they need to perform are clearly marked out. And then at the top of the form here, there's just different levels where you can mark your learner. Did they require verbal prompting? Were they able to do it almost independently with just some minor errors? Or is it something that they were able to do totally independently? You can also do a direct observation called mini clinical exercise, which is really just a focused clinical interaction where you're going to do a brief 15-minute snapshot of observation of your learner with the patient, and then make sure you do debriefing with feedback afterwards. And just similar to our direct observation procedural skills, there are many different parts of the patient encounter that you can observe. It doesn't necessarily need to be the full thing every single time, but focusing on one of these pieces and telling your learner what it is that you're going to directly observe, whether it's the history, the physical, counseling the patient, it can be helpful for them to know so they know exactly what they're going to be assessed on. And you can think about their organization, efficiency, communication, and professionalism at any point in this process. And then entrustable professional activities, or EPAs, are another direct observation assessment tool we can use, which are workplace-based tasks that you see your trainees performing at on any given shift or any given rotation. So for a senior resident, one example could be leading a team. And as you observe them doing that, you're going to think about how much supervision they really require to do that task. And you're going to think about, is this something that they need direct observation for, indirect? Can they do it unsupervised? Or are they advanced enough where they can instruct their junior colleagues to do this now that they're at this level? The thing you'll recognize still is that at the bottom of the slide, debriefing with feedback is here once again, which is really what I wanted to hit home, is that this is the key point of any of these direct observations, is that debriefing process where the learning happens. So when you're thinking about doing direct observation with your learners, we talked about how it's really important to establish expectations so they know what is going to be directly observed and what you're going to be assessing them on and giving them feedback on. We know how busy the clinical environments can get, so sometimes it's helpful to incorporate these early in your shift or early in your day before things start to maybe get crazy, so that you make sure that your new medical student gets that direct observation, performing a history. it's helpful to avoid repetition of tasks too. So you can always let your learners know, oh, I'm going to observe you during doing the neurologic exam today. So they can go do their full history and the rest of their exam, but then you're going to go in together. And instead of having both of you do the neurologic exam separately, you can directly observe your trainee doing that. It's also helpful to strategically position yourself in the room, especially if you're watching a trainee take a history, so that your patient is really focused on the trainee. So you're kind of off to the side instead of having your patient still directly looking at you the whole time, because you really want your trainee to still be able to establish that therapeutic relationship and that eye contact. And along those lines, it's helpful to minimize any interjections. So if you have any questions that your trainee maybe forgot to ask, saving those until the end can be helpful when you're directly observing. So this is just a summary. I know this is a very long list of tools that you may use, but hopefully there's one or two things that you are interested in learning more about, and you can look at previous resources that have been published online so that you can maybe take this into your clinical setting when you're thinking about formative assessments using either indirect or direct observation. So then now let's hit our take-home points and wrap things up here. So overall, formative feedback is key to learning. That is one big piece that we really want you to take away from our talk today, where we are working with adult learners and we want to make sure that these formative assessments are different from achieving that goal of a grade at the end of a rotation or the end of a course. We really want to focus on the key knowledge and skills that we want our learners to take away. We want to make sure we're providing feedback at the right time and frequency based on the level of our learners. Transparency is really important about what you expect from your learners. And then it's also really helpful when you go through these teaching encounters with them to then give them resources for what they can do for additional practice or additional learning so that they can keep improving on what it was that you all identified was something that they can change in order to keep moving their practice forward and keep improving.
And then lastly, remember also that formative assessment is key to teaching. So as we talked about why people do things, one of the motivations for people to learn something is because it helps you in some way. So formative assessments for your learners will actually help you be a better teacher. It'll help you understand if there are patterns that your students are continually not getting correct, that maybe that's a gap in how you're teaching. It will help you, I think, really recognize this idea that sometimes if students can't do something, it's not the student's fault, it's our fault because we haven't set up the process for them appropriately, or we haven't set up the ability for them to get feedback on an assessment and practice again. So I would just encourage everyone to think about feedback, which you're going to hear about in the next session, as a really important part of this whole assessment, feedback, learning triangle that I think is really important, and that you as the teacher will continue to grow just like your students will continue to grow if you use formative assessment appropriately. Here are some references, which I think you should have been provided also in writing form, and then we will unshare and see if anyone has any questions.
Well, people are thinking what questions that they themselves would like to answer. I think one question that not infrequently comes up about assessment, particularly some of the verbal questioning ones, is how do we keep those productive and not feeling as though we are in the US, the term is pimping, and which is somewhat derogatory, but not feel as though we're torturing someone during the questioning.
So this is a great question because we want to avoid those like negative emotions that may come out of our learners if it feels like it turns into one of those sessions. So really establishing those expectations is helpful when you're first working with your learners, to let them know that these questions are intended to help advance their practice, and so that you know what to teach them. That's something that I tell, especially new students when I'm meeting them for the first time in the emergency department, is that I'm going to be asking you these questions so that I can know what things to focus on, so that I can teach you things that you haven't heard about, because I don't want to be teaching you things that you already know and I'm just telling you things that isn't going to advance your practice at all. But I also don't want to be teaching you things where it's at this level, but we haven't gone over the basics first either. So I think establishing those expectations can be really important. And then just also being cognizant of how many questions you've asked your learner, because you don't want to feel like it's just rapid fire and no breaks in your questions. So I think it's helpful to really think about the 1 or 2 key teaching points you want to take away from maybe that one patient encounter. And then maybe they'll go see another patient and you'll have a second thing that you'll teach them from that second patient encounter, and so on and so forth as you go through your clinical day with them, because you don't want to have like 10 things that you're trying to teach them from one patient encounter. You really want to break it up into those small chunks so that things are digestible.
And we have a question to clarify the difference between summative assessment and evaluation.
Yeah,
so really getting into the weeds.
Yes, these are the confusing ones for sure. So I think that the easiest way to think about it and the most simplistic way to think about it is that assessment in general is about people and evaluation is in general about programs. Now, that can overlap, but the easiest way to start to think about that is that you go through a class and students take quizzes and they get feedback, and that's their formative assessment that they now know they haven't done something correctly. And at the end of the class, they take a final exam, which is their summative assessment. But at the end of the entire semester, the dean of the school takes all the grades and looks at how people did. Were there areas that didn't perform well or areas that performed super well that maybe it was too easy? And then that is an evaluation for the instructor of the performance of the entirety of the students in that program. So assessment is often more individualized and evaluation is often more generalized or at the programmatic level.
Well, if I can add another example.
Please.
So for example, in an OSCE station, we will be doing OSCEs later, but generally you have a checklist that you're taking off the resident. So in a summative assessment space, he did this, he did that, goes forward, comes back, does something else. You've done all that. But at the end of that exercise, you can evaluate that performance. Sometimes some OSCEs will have something they call a global assessment. So even though the checklist is there, you're ticking, was able to do this, was able to do that. Was the candidate doing it the right way? Did they follow the steps completely? So that is more of an evaluation of how they did it. But the steps of how to do it, you can take it. So he was able to check the eyelash, but then he went and did something before he came back and do this. Everything is ticked, yes. At the end of the day, gets all the ticks, but then you can evaluate that performance and give a different thing. So sometimes maybe this will help distinguish between the summative assessment and then evaluation. Over.
I think you're also bringing up another key important point about some of the complexities of medical education is that we are often guilty of blurring these together and not being clear to trainees that there are consequences to what we are saying are formative assessments. So we are also guilty, I think, of creating problems at times.
Absolutely. If you make the formative assessments too important to the progression of the student, then they're no longer truly formative, they're summative, right? So you have to make sure that the level of what the stakes are, that there's still opportunity for change and growth and progress before a final assessment or an evaluation. Otherwise, it's not truly formative because it hasn't given them the opportunity to grow and develop and practice.
Okay, let me see if I can manage to navigate time zones a little more accurately than I did last time. We have about 8 minutes until we are scheduled to start with our next session on verbal feedback. And actually, before I break off, someone just put in the chat a very real problem of when you have 2 weeks to teach a whole curriculum to classes of 200, all techniques are needful to enhance learning. That is an overwhelming prospect. So yes, making sure your learners move and that you can be nimble under time constraints is incredibly difficult and important. But we'll regroup here at five past the hour and let everyone have a brief break. And we will hear from Drs. Haas and Sala about verbal feedback. Welcome back, everyone, for our third and final session. We have a terrific session about feedback today from our two presenters, and I will turn the microphone over to them.
Excellent. Thank you, Dr. Hobson. I'm just going to go ahead and share my screen. Can you hear me all right?
Yes, we can.
Yes, I can.
Excellent. And are you able to see my slides?
You're good. Go ahead.
Great. All right. So first, we would just like to thank this group for allowing us to be here and go ahead and introduce ourselves. So my name is Mary Haas. I'm an assistant professor of emergency medicine at University of Michigan, and I teach learners across the continuum, including medical students, residents, fellows, and faculty. And of course, with all of my teaching interactions, I've found that feedback is truly a critical topic for all domains and all levels of training. And with that, I'll hand it over to my colleague, Lorraine Salat, to introduce herself.
Thank you, Mary. It's a pleasure doing this with you. I'm Lorraine Sala, a biomedical educator with much focus on effective feedback as a formative assessment tool. And I'm also an academic member of the Department of Physiology at KNUST, where I teach preclinical students in the Allied Health Sciences Physiology with a specialty in reproductive physiology. Research-wise, I'm into the impact of complementary medicine on fertility and reproductive outcome. It's great to be with all, and the fact that we are here to share information and talk about feedback as an integral part of all learning processes. Mary?
Thank you, Lorraine. And lastly, before we move any further, I just want to thank the other educators that have helped me develop this talk. Much of this content was developed by or in conjunction with two of my colleagues, Laura Hobson and Brendan Munzer. And I'm also grateful to Lorraine for her contributions. So with that, we'll move on to our learning objectives. So there's three key things that we would like our learners to be able to do at the end of this talk. That's to recognize the complex nature and the importance of feedback in learner development, to demonstrate best practices for providing effective feedback in the clinical setting, and to identify challenges to giving feedback and develop strategies to overcome these barriers. I want you all to watch this, and if you have any impressions, please put them in the chat.
If you ever want to get out there to fight dragons, you need to stop all this.
But you just pointed to all of me.
Yes, that's it. Stop being all of you.
So what did you all think of that feedback interaction?
I don't know what he was supposed to do with that information.
Yeah, it was a little bit overwhelming. I mean, it's good that he was giving feedback, but probably not the best way to go about it. Let's show another example here.
Good night, sweetheart. Night, Mom.
You may recognize this from the Disney movie Monsters, Inc. Yes, I'm getting some excellent comments in the chat.
is it?
My friends call me Phlegm.
Uh-huh. Mr. Bile, can you tell me what you did wrong?
I fell down?
No, before that. Can anyone tell me Mr. Bile's big mistake? Anyone? Ugh. Let's take a look at the tape. Here we go. Right. There. See? The door. You left it wide open. And leaving the door open is the worst mistake any employee can make because...
It could let in a draft?
It could let in a child.
Oh, Mr.
Okay, so you've seen two examples now of feedback. And, I guess you can find some positives for both of them. You all mentioned some of the things that you personally, it was good that he was receiving feedback in the first example, but it wasn't focused. He just kind of, spurred out a bunch of stuff. It wasn't specific. And the poor learner was like, what am I supposed to do with this? And what about the second example from Monsters, Inc.? What did you notice about what went well or what went poorly? And maybe pulling in some principles from that last talk, it was great that it was based on direct observation. They were performing essentially a simulation here, and the feedback was based on actually directly observing the learner. It was specific, but it was super harsh. It wasn't very balanced. There, wasn't really anything very constructive. And I would probably feel terrible if somebody gave me that feedback. And thanks to those of you commenting in the chat. The second feedback was specific and simulated more learning and reasoning, but could have been developed in a more constructive way. And the reason for showing you these examples is just to highlight that even though feedback is really important, it can be really hard to give effectively. And I think, if you're not careful, you can actually traumatize your learner. So it's important to know the best practices for doing this.
There's actually a great comment from someone that just popped up in the chat with, was that really the mistake? Mary, do you want to comment on that?
Yes. Yeah. Well, you know what? The problem is I can't hear the audio on my own computer. So I've watched that clip 1,000 times, but I couldn't actually hear to remind myself what they were saying. But yeah, I know. I mean, it's possible that the feedback that somebody's being harsh about isn't even the most important priority and what you need to adjust in the learner. So you can see there's obviously a lot of things that could have been better with both of those interactions. So what is the evidence? What is the research out there looking at feedback say? There's actually a fair bit out there in the literature, and we're going to touch briefly on that to guide our discussion today. Spoiler alert, it boils down to the fact that feedback is complicated, but we can break it down to 4 main points that the literature informs us about. One is that learners overwhelmingly want feedback, and they say it's important for their learning. Despite this, learners often don't specifically ask for feedback. Teachers recognize the importance of giving feedback and say they do it. However, learners say teachers don't give enough feedback and want more. So clearly things are not adding up here. But if you look at a few studies, it can kind of give us some insight into why there's that gap. One really interesting study illustrated just how complicated this can be. This was a study by Bowler and Rogers back from 2006. And in the study, they had 2 groups of medical students who received identical instruction on surgical knot tying. However, group 1 received specific constructive feedback on how to improve, and group 2 received only general compliments. The authors found that students who received specific feedback improved, whereas those who only received compliments did not. However, the students who received general compliments rated significantly higher satisfaction than those who actually received constructive feedback. The authors concluded that student satisfaction is not an accurate measure of the quality of feedback. Satisfaction ratings responded more to praise than to actual constructive feedback, whereas actual learning outcomes is more of a function of receiving true feedback. So despite students expressing this desire for feedback for learning, they tend to only really like it when it's interpreted as praise. This can make them fearful to ask for it and faculty fearful to give it. Another really interesting study examined the accuracy of students' ability to self-assess their clinical skills and to identify behaviors needing improvement. They looked at the impact of giving feedback via performance benchmarks on their ability to self-assess and tried to ask themselves, did this make that behavior any more accurate? So in the study, they had standardized patients score students on checklists during an OSCE, and then students assess themselves immediately after. 1 month later, the students watched their own performance on the video and reassessed. Some of the students, but not all, received performance benchmarks. That means they got the markers of their own score compared to the rest of their class before they reviewed, and others did not get this data. The authors then calculated how well student self-assessment correlated to the SP's rating of them. Initially, self-assessment correlated weakly with the SP ratings, but with feedback, that correlation improved significantly, and it remained weak without it. Interestingly, low-performing students showed the greatest improvements after receiving feedback, and the authors concluded that student self-assessment accuracy is poor, but the promising thing is that it can improve with performance feedback. The study highlights that even though feedback's critically important, even though feedback's hard to hear sometimes, especially when it's constructive, it is critically important because it can really make a difference. So that brings us to one of the big questions. Why does feedback matter? Why are we even talking about this? Feedback matters because it's really critical to guiding learners in meeting goals. Feedback can reinforce desirable behaviors, correct mistakes, provide formative assessments. It can also help clarify expectations. Really importantly is that it's also an opportunity to develop a relationship between teacher and learner, because when done well, it allows for two-way communication between the teacher and the learner. It shows that the educator is committed to the learner and to their education. Without feedback, clinical competence is achieved empirically or not at all. If feedback and evaluation are not given, learners are inclined to fill the vacuum with their own assumptions, which may or may not be accurate. We know from that prior study I alluded to that it's not always very accurate. And without feedback, our learners often have the sense of being adrift in a strange environment. To paraphrase the American baseball player Yogi Berra, if you don't know where you're going, you could end up somewhere else. Even worse is that students may develop their own system of internal self-validation, which excludes evaluation and feedback from external sources. This is a dangerous stage for a learner to reach, because at this stage, no one can alter their opinions about themselves, and they can become immune to feedback. So bad habits really become ingrained and difficult to change. So clearly feedback is important, but why is it so hard to give? What are some of the barriers that you all have noticed in your practice? Go ahead and enter them in the chat. I know one big time constraint for me in the emergency department is just feeling like we're so busy. There's so many competing demands. And Dr. Hobson brings up a great point. Sometimes you get to the end of a teaching interaction and it's really hard to think of something. You're like, man, I wish I would have taken some notes. What else? Have you ever had the scenario where maybe you've gotten to work with a learner like for one day and then you never see them again? That's also really tough, right? Because when you don't have a relationship with somebody, you may not have that rapport and it can be even harder. I think there's also often a fear of negative consequences. Exactly as our commenter in the chat just mentioned, maybe you're worried the person may not take the feedback well, and it can be scary or painful to make somebody feel bad, even though you're trying to help them. Oftentimes too, the environments in which you're working in are just not very amenable to giving feedback, especially when it may be sensitive or constructive. Maybe we're working in a super busy, loud environment. Another person mentioned cultural differences, knowing how to express yourself in a setting different from yours without being misunderstood. These are excellent points, and I think very common things that we all face as educators. So we've established from this last lecture that formative feedback is an integral part of the learning process. And with that, we want to talk about some ways you can get around these barriers and how you can actually give effective feedback. And with that, I'm going to hand it over to my colleague, Lorraine.
Thank you, Mary. Formative feedback is indeed an integral part of the learning process. Thank you once again, Mary, for echoing the rationale for giving feedback and the fact that it is really not too easy to give feedback. Now let's review some strategies to help you get around some of these barriers and give good feedback, bearing in mind that effective feedback enriches the student's learning experience and enhances the skill and capacity for reflection, which is actually an essential for the development of expertise and lifelong learning. And when feedback is handled well, it can actually enhance teacher-learner relationship and lead to beneficial changes in the learner's behavior. The QR code on the slide will lead you to a helpful publication on which much of these best practices advice is based on. Establishing common goals and expectations is necessary at the beginning of your time together with a learner. Being explicit about setting goals can help both teachers and learners to be on the same page. So you may want to ask your learner what their goals are, tell them what your goals are and expectations. are for them, and to make sure that their goals and your goals are aligned. You need to ensure that they know what to expect and that you would give them targeted and regular feedback on their performance meeting these goals. It may be formal or informal feedback. You explain to them that such feedback sessions are meant to enhance their performance and promote their growth rather than establish grades. You let them know that they can also initiate requests for feedback sessions. These actually would set a stage and make the learner more comfortable and engaging. As we alluded earlier, there's been a mismatch between perceived amount of feedback received versus feedback that is actually given. Learners would frequently say they receive insufficient feedback despite teachers saying they give it frequently. Part of this may be due to a lack of established feedback relationships between the teacher and the learner, and a discordant expectation for feedback frequencies, and even the methods that are used for these feedback sessions. Another problem may be that the learner might not even recognize that feedback is happening. Feedback should be clearly labeled to address this mismatch, set the stage, and prime the feedback process. Feedback can be effectively labeled verbally by requesting a session and identifying it as it is with the learner. Making it expectant is also very important. In that way, the learner doesn't automatically interpret the fact that they are receiving feedback as a negative thing. Rather, it becomes a culture and part of the normal workflow. If your learners know you are someone who gives feedback after every encounter, they will be primed for it and they are more likely to interpret it constructively. Creating a positive learning climate is very important in maximizing the efficacy of feedback. The learning environment that you create should be one where there is mutual respect, and it should be very apparent that the teacher and the learner are working together as a team to help the learner meet the set goals. Having a mutual trust and respect during your feedback sessions makes the trainees or the learners more susceptible to feedback. There are some other additional factors that you may want to inculcate to optimize the favorable environment. You could deliver feedback in a private setting, and that's more like formal feedback as compared to the informal. You need to think about your body language. You need to sit down with your learner in a well-planned environment, well-planned furniture arrangements, and this would help minimize their sense of a power differential, because that could be quite intimidating. Feedback should be delivered emphatically. It should be gentle, very caring, and it should be given supportively whilst you address the strengths and the mistakes of the learner as you observed. A feedback session should be viewed as a two-way conversation. In this two-way conversation, the learner would have to play a vital role in self-assessment, whilst the teacher is also ready to receive feedback from the learner or the trainee. This would lead to an interactive but a learner-centered approach, which is very important in all settings of learning. And this would incorporate the learner's perspective in the entire feedback process. Knowing some importance of self-assessment would encourage us or would help us to promote this two-way conversation. The importance of self-assessment would encourage learners to develop into reflective practitioners, which is what educators are actually looking at. This would help them to be lifelong learners. Opening the feedback session by inviting the learner to self-reflect and self-assess may actually invite the learner to ask a few questions, make a few submissions that would require a response from the teacher. And this can actually stimulate or start that two-way conversation or that dialogue. This is usually best achieved when the trainer, the teacher would ask the learner a few questions, and most of the time, open-ended questions are the best type of questions to use. You can, for instance, say, tell me how a particular observation went. Tell me how a particular event went. What do you think you did well that related to your goal? This would also actually allow the teacher to determine how much the student thinks is at stake in each feedback session. The learner may actually also bring up some points that the teacher has already set to bring up from his or her observation, and that actually softens the perception of harshness, especially when the feedback is a bit in the negative, and it helps make feedback corrective, sensitive. It makes it more acceptable by the learner. Actually, multiple studies have shown that this type of learner-initiated feedback was perceived as more instructive than the teacher-initiated feedback. Direct observation should actually form the basis of each feedback session you have with your learners. This means you are providing feedback on behavior you have witnessed with your own eyes, and you have a first-hand experience. Direct observation by the same teacher in a number of interactions actually results in accurate and constructive feedback. Studies have also shown that feedback based on direct observation by the teacher is found to be more acceptable and instructive to trainees than feedback that is based on second-hand reporting. That is when feedback is being delivered to the learner that was generated, a report was generated by someone else and given to the teacher that is delivering the feedback. Feedback based outside direct observations is more likely to be written off as less credible by the trainers. So as often as is indicated by learners, paucity of feedback could also result from a failure to observe a student's performance firsthand. Time is very important here. Generally, the sooner feedback is provided following direct observation, the better the learner's chances of improving activities in the future. Feedback that occurs soon after the encounter would allow the encounter to be still as fresh in its context, and the learners would have a better memory of what they were thinking and feeling at the time of the encounter. It would also help them incorporate the feedback more quickly so that they can do things differently at a quicker interval. But there's one thing you need to bear in mind. Although giving timely feedback is important, don't forget all the other best practices. Giving constructive feedback in a public setting during an emotional encounter may not be the best approach. Sometimes waiting the extra minutes or hours until the shift is over is important to find the appropriate space and the time to give feedback that is so sensitive in a very effective way. So you would schedule the feedback session at a time that is convenient for both yourself, the teacher, and the learner. And this gives both adequate time to prepare, to give, and to receive. And most importantly, the purpose of the meeting should be made known to the trainer. As teachers and as educators, sometimes we are not very conscious about how much information we bombard our learners with. But feedback is most significant, has most significant impact on students' behavior when it is regulated in quantity and it's provided on a specific task or performance in clinical teaching. So it's always best to actually just focus and prioritize 2 to 3 key points for each feedback session. With too much information given at a time, the learner may even forget and also get confused as to which is the most important message that you're trying to get across for that particular feedback session. Naturally, there are also diminishing returns after a certain point. So keeping it focused on what the learner can realistically absorb is very, very important. You should always base feedback on the behaviors directly observed and avoid making statements that describe the person you are giving the feedback to. That is a not. You need to also limit it to a remediable behavior. Following the description of the behavior with a suggestion for a change can also make feedback more effective. For instance, during a feedback session, instead of telling the learner that you are inefficient, there could be a better approach of handling that. You could probably just say that I observed that you devoted a significant amount of time to some task that actually another team member could have helped with. And involving another team member earlier would help the total completion of other tasks. So you do it gently and do not actually focus on the person, but rather the behavior. You need to avoid projecting intentions on the student's actions, making assumptions and over-interpreting the situation. Interactive feedback sessions would always help avoid assumptions, and it will help reduce how judgmental sometimes we could be and rather deal with decisions and actions that were taken and need to be taken in the future. One thing that you should be careful not to do is not to assume that the student knows the consequences of continuing with certain specific behaviors. This would actually allow you to follow up by asking for the learner's perspective. In giving feedback, credibility is very important. Who gives the feedback may have as much impact on what the feedback is and how it is delivered. Naturally, learners are more likely to internalize and incorporate feedback that comes from someone that they trust and someone that they admire. So the nature and quality of that person's relationship with the student receiving the feedback could make them more credible, as well as the student's perception of the person's intentions. So being knowledgeable about the subject in which you are providing the feedback and demonstrating that you follow the same practice that you're actually advising your learner to do are both important aspects of being credible. You should have a good understanding of the curriculum and the learning objectives. As it is said, practice what you preach. So direct observation helps with the credibility piece as well, because learners know the feedback is coming from someone who has actually observed and witnessed the behavior and is not giving the feedback from secondhand or handed down information. You must always conclude your feedback session with an action plan. You do not go without an action plan. And this action plan should be a collaborative development between the teacher and the learner. At the end of the feedback session, you need to develop an action plan with your learners for how they would incorporate the feedback that has been given. And in order to promote your learners' reflective skills, invite them to generate their own ideas. And it will amaze you. Young people of today have ideas that you can also pick and run with. They make their own suggestions and they modify them as needed. So before and after feedback, on the road to success of giving effective feedback, you must prepare and reflect. So as we've already discussed in some of the best practices that have been suggested, a productive, formative feedback session requires attention to key elements involving the structure, the content, and the format of the feedback. So before giving feedback, you must prepare effectively and adequately as a teacher. It would help you plan before the actual interaction will take place and will help with a smooth transitioning of events in the interaction. So you need to plan what you say, bearing in mind the stage of the learner, the level of the learner, because our learners are all at different levels with respect to their knowledge, their level of maturity, and how they understand things that are put across. So you also need to review your notes based on direct observation and choose a few items a couple of them, that's which you would focus on during a particular session. That would help you, like I said earlier on, limit the quantity, and it would ensure that you are specific. You are giving feedback on specific observations. You have to make sure that you have enough information, especially if feedback is secondhand, which is usually not advised and is usually not the best, but these could actually happen. So to have enough information, you have to obtain specific, documented, behaviorally based information. You need to find out from other people who were around that you could probably collect constructive information from. Then after giving the feedback, as a teacher, you need to take time off to reflect on how that interaction went. It's very important. So some of the questions and some of your thoughts may include how effective was the interaction? How could things be done differently during the process? Was I well prepared? Do I need to document such interactions? Would I need some extra help? Do I need to develop some strategies for the future? So as effective and regular feedback sustains good practice, encourages self-reflection, and it motivates learners to work towards achieving their objectives, the delivery style can impact the student's outcome. Feedback can either inspire students to reflect and improve their performance, or be totally undesirable and demoralizing. So we need to use some structural methods and models for providing feedback. And Mary would actually help us to go through some of these structured methods and models to give efficient feedback. Mary?
Thank you, Lorraine. So now we'll chat a little bit about methods for giving feedback. And I would say not everybody uses a model, but it can be helpful to be aware of what's out there in case you need some help getting started with building this into your practice. Much has been made about the feedback sandwich in medical education. The expectations with the feedback sandwich is that you should frame your negative comments, symbolized by the poop emoji on the slide, with 2 positive comments to be more palatable for the learner. And this is the approach I think most of us kind of have grown up with in traditional medical training. And you know, it's not all bad. There's some strengths, but definitely some weaknesses to this approach, and it's not the only way to do it. So, you know, starting off with positive feedback, it can enhance a learner's sense of safety, and I think that's one of the main strengths of the approach. But there's several limitations. So one is you know, if the learner kind of knows this is coming and this is the approach that they're used to, they may just tune out during the positive commentary, waiting for the hammer to drop, waiting for the anticipated constructive feedback, and they may not even hear the positive comments. Another disadvantage is that this really emphasizes a single encounter and delivery of feedback, which is only an active process for the person giving the feedback and kind of inactive for the recipient. It's kind of a one-way, you know, approach rather than a two-way conversation. And it doesn't really pay heed to the relationships between individuals. And I think that's a theme you've probably heard over and over through this talk, is that much of giving effective feedback is, you know, prioritizing and having good relationships with your learners. So the sandwich model emphasizes the responsibility of the individual giving feedback with little to no focus on the role of the receiver of feedback. There are many models out there. I just want to focus on a couple that I find particularly valuable, even if you don't use them exactly, just to be aware of them and the ideas behind them. The ADAPT model is one that can be a valuable approach, and ADAPT stands for ask, discuss, ask, and plan together. So in the first step, the ask step, you as the teacher ask your learners to evaluate their own work and ask for specific feedback, kind of that prompt for self-reflection that Lorraine mentioned. The learner starts first. They're encouraged to reflect on what they did well, what they need to improve upon, and how they will do so. So an example of that might be you as the teacher saying, let's talk about how that procedure went. What specific parts went well? What parts were you uncomfortable during, or what do you think might need improvement? Then you get to the D, the discuss. So this is where you have that active two-way conversation with your learner about their observations and their self-assessment, and then compare this to some other standard, either an external standard or the teacher's observations. And the educator can share their thoughts on what the learner identified in the step prior. So as an example, the teacher may say, I agree with you that your ability to communicate with the rest of your team about the intubation plan and perform an effective timeout for the procedure went well. I also agree that you could improve upon patient positioning. For obese patients, applying a ramp of towels under the shoulder can assist with your view. And obviously that's specific to specialties where we're performing intubation, but you could see how that might adapt to other clinical scenarios. And then the last phase is the APT, ask and plan together. So this is where the educator asks the learner what the next steps for improving are and creates that action plan that Lorraine mentioned jointly, collaboratively for how the learner can improve. The learner, however, should be the first one to come up with the strategies. So you as the educator may say, I know it can be difficult to remember all the necessary steps as part of the preparation to intubate. The next shift we work together, let's strategize about patient positioning prior to proceeding with the procedure so we can optimize everything in advance and increase your chances of first pass success. So you could see how that model might be employed in the setting of a procedure. Another approach that I like is the ECHO approach. And I like this because it really takes into account and recognizes the importance of the receptivity of the learner to feedback, to change, and the influence of emotions on the process. I think many people are surprised and not prepared to handle emotions that can come from receiving constructive or sensitive feedback. And this normalizes it and makes it an essential part of the conversation. So in the ECHO model, step 1, the E stands for exploring emotional reaction. So most feedback, particularly unexpected critical feedback, can have an initial emotional reaction that might actually impede or facilitate the acceptance to change and might improve with external feedback. This step focuses on really acknowledging and exploring that emotional reaction to external feedback. For example, one way that you might engage in that first step is asking your learner, after you've given them the feedback, what do you think about this feedback? How does it make you feel? Step 2, the C, stands for clarifying feedback content. This aims to clarify the specific content as it relates to the trainee's actual workplace performance to enable them to use it for improvement and to check for understanding of the feedback. For example, do you have any questions about what we discussed? Is there anything that doesn't make sense? Can I clarify anything? And then step 3, the O, stands for outcomes promotion. This is where you seek to confirm the learning needs of the student and develop a plan to meet their needs and result in improved performance. Again, an action plan. Are you seeing a theme here? So for step 3, you want to clearly define the objective, include specific measurable steps to achieve it, and check for understanding. So for example, in order to increase your efficiency and the patient load you can effectively handle, what might you do differently during your next shift? Give the learner the opportunity to suggest some examples, but you should have some suggestions in your back pocket as well. And all of this is well and good, but if you really want to be able to engage in effective feedback as a part of your normal workflow, and institution and program, it's really critical to look at the big picture and develop a culture of feedback. We can't just rely on individual teachers and learners. It really requires us to create this culture within our programs and our institutions, and events like today are part of that greater goal. So I thank you all for being here. But what else goes into creating a culture of feedback? Simply mandating that your teachers fill out a form every time they interact with a learner, that will increase the amount of feedback given, but is it necessarily going to increase the quality? Not necessarily. We need to really train our faculty and learners how to ask and receive feedback. And verbal feedback needs to be encouraged in conjunction with written feedback because learners generally find it substantive and timely when it's given verbally, but there also needs to be in written form so that program administrators can track learner progress and strengths and weaknesses. Providing teachers with dedicated time through teaching shifts or direct observation opportunities can also help promote this and take away that barrier of often being too busy with other competing demands when you're in the clinical space. Facilitating scheduling to promote long-term relationships can help. This is hard, obviously, logistically, but it can make a big difference. Sometimes the fact that we only work one day with a given learner every several months can make it really hard to build that trust and credibility that it takes to give effective feedback. And we should really focus on developing a culture of safety, not a culture of niceness. A culture of niceness where we give vague positive commentary like, good job, just to be polite. It doesn't promote learning. When we have that kind of culture, negative feedback is often withheld for summative evaluations or closed-door discussions with the program leadership. This breeds mistrust. Instead, learners should be given constructive feedback early and by the people who observed it to give them the opportunity to act on it in a timely fashion. In addition to the niceness culture, another thing that can combat a culture of sound feedback is the culture of assumed excellence. This is something that prestigious programs could often fall victim to. In this, a program or an institution's prestige leads to assumptions that everybody's outstanding and that negative feedback statements are not permitted. This can also be applied to individuals, also known as the halo effect, and it can result in trainees with a reputation of being excellent, receiving less coaching and less teaching than they should. Errors may even be overlooked, and these learners can suffer from this halo effect. The culture should be one where everyone receives constructive feedback, not just struggling learners. So we need to make sure that we're aware of these biases. And we also need to emphasize the importance of feedback among all members of the team. Regular training for our faculty on how to provide effective feedback, making sure they understand the educational goals of the program they're teaching in, and giving them feedback on their feedback. Feedback should not be unidirectional. So emphasizing that culture of growth with reciprocal feedback between learners and educators is also important, where we normalize that we all have strengths and weaknesses and we all have room to grow. And we should empower and encourage our learners to be drivers of change. All of these types of initiatives take time and resources, but they're important. We should continue to prioritize it. So with that, these are our take-home points. Effective feedback requires a two-way interaction involving the teacher-learner dyad. Effective feedback is specific, timely, based on direct observation, actionable, and from a credible source. Make your feedback expected, label it, optimize the environment, consider alternative models beyond the traditional sandwich, and engage in broader efforts to support a culture of feedback. Again, this QR code links to that article that much of this was taken from. That's a helpful article. And with that, we just want everybody to end with their own goal. So if you could put in the chat one specific goal or change that you'll take from this talk on how to give effective feedback for your next time working with one or more learners, write it down in the chat, write it down somewhere else and commit to it. And hopefully you can take something with you the next time that you're in a position to provide feedback. And as you all think of your goals and type them in the chat, we are available for any questions.
We want to thank everyone for staying through a long set of sessions. Our next sessions are going to be on the 23rd. We're seeing some great personal goals around feedback starting to pop in the chat. I'd encourage you to keep floating those in. If there are specific questions, feel free to put them in the chat as well. Mary, if you'll end SlideShare, I'll pop up the QR code for our feedback form in the spirit of all of this. Yeah, we're seeing great goals of making sure that everyone gets feedback, not just people who are struggling. Plan the details of a feedback meeting before starting it. And honestly, I lecture on this topic, and I will still go to people I trust and say, tell me how this sounds before I open my mouth and insert my foot deeply, and maybe irreparably harm a relationship or a trainee. And someone wanting to commit to using the ADAPT method to help with feedback. But once again, we thank everyone, and we thank our presenters throughout the course of the day for all of their work preparing this and presenting during the day. Next week, we have 2 sessions that our presenters this week nicely gave advertising for. The first of which is a session on how to effectively develop and use OSCEs. And the other follows up on our session about simulation with a session on debriefing during simulation. And we certainly hope to see everyone in the audience there as well.